Hello, everyone. Happy exams. Thank you so much for coming today. I know the experience was,
لازم تدوسي على ده، ما تدوسيش على ده دلوقتي عشان نسقفل.
yes, please mute your mics. Thank you. We are going to discuss today what happened during July 2023 exam. As I can see, I can turn this meeting into group therapy because honestly, I have got many very depressing feedbacks about the exam. So if you wanna turn this into a huge group therapy, it would be fine. I don't mind at all. In my personal opinion, I would like to be a psychiatrist if I'm not obstetrician, by the way. So, and I know what happened in the exam. I know it's okay. It happened. Not all exams are easy or very familiar. And by the way, such exams are a really good opportunity for some candidates. It really be fair for some candidates because familiar questions and recalled questions would be good for someone who just know questions and answer, question and its answer. Does not give you a chance to think, does not give you a chance to express your knowledge. But this kind of exams I really like. Really, honestly, I like those exams. It reminds me of 2015 exam for part one and part two. Both of them was new questions, the same topics, but new questions, um, new formulation of the question. And that is good, by the way. That is good. This is not bad. Okay, first of all, I tried to imagine how would we go for this. So I put some aims, and inshallah we are going to have the maximum benefits of this meeting. We are going to gather as much information as we could about the exam questions and try to analyze them, okay? And we're gonna highlight the weak points. This is very important, guys. This is why we are here today. I'm not going to revise the questions and try to get the answer, and every one of you would be depressed because I have missed this and I have missed this. Because honestly, how would I know the right answer if I don't have the question in my hands? Every single detail can vary in the answer. Every single detail. And I'm going to tell you why. And that's why I will keep saying, me or Dr. Rabah, please don't depend on recalls. Please don't depend on recalls. Recalls are incomplete. This is not the exam like. And you know what the college play on? They play on your vision of the question. They know, they know that you follow the recalls. They know that you are familiar with keywords. So whenever you are going to find a specific keyword within the question, you are going to answer a specific answer and you forgot all about the scenario. You forgot all about other details. Right? Am I right or wrong? You can talk to me if anyone wanna say something about this. Did you feel this what happened in the exam, that the question have a specific keyword but the case was long? There was so many details, and if you just depend on the keyword, you might answer it incorrectly. Right? Yeah, I know. And by the way, Dr. Kanji in the very beginning in his book talked about this. He talked about being familiar with the question. This is the, I think, my opinion, the most common trip that can anyone jump in. They think that they know the question. They think that, yes, I know this. And unfortunately, he didn't take care of what is the scenario. What is the scenario talking about? I can give you an example. I think there was a question about, I don't remember, postpartum or post-operative patient. I think postpartum patient, yes. And she has respiratory symptoms. She has symptoms of pulmonary edema, right? And I know that most of you would think of peripartum cardiomyopathy, right? But the important point here, does this patient has a previous history of chronic illness? Does this patient had a chronic history of hypertension or cardiac disease? Because if so, she's not peripartum cardiomyopathy. So this is a very small detail that you should know about before diagnosing someone with peripartum cardiomyopathy. I'm just giving you examples, right? Another question that I remember from your candidates was post-operative complication, I think, which was about absent bowel sounds and fullness of the abdomen, pain, right? And the key word was absent bowel sounds. However, there was a CT with dilated bowels and incisional hernia. So when he said, when he told me that there was absent bowel sounds and so I told him, is it ileus? Is it ileus? He said there was a CT. Okay, what was in the CT? That there was incisional hernia and defect in the rectus abdominis. If I'm wrong, you can correct me because I'm depending on someone recall. Right? So now it's different. It's totally different. Now we are talking about a great possibility that this is bowel obstruction because of the hernia. So now I don't know the right answer. I don't know because it will depend on the whole scenario. Whether the absent bowels was before the hernia or after the hernia. He don't remember. He don't remember. Was there any kind of defecation, vomiting? He does not remember. Okay, so you just remember that there was a TT with incisional hernia and defect in the rectus abdominis? Yes. Okay, can you remember the CT? How it was? There was some fluids in the pelvis or the abdomen, something like this. There was vomiting. Okay, so now we are talking about a very great possibility of obstruction, not ileus. See, every single detail can cause a great impaction in your answer. So I can say for sure that the first thing that we can learn from this exam is when you read the question, don't read it as a familiar question. Don't try to make it familiar with you. Read it and deal with it as a brand new case. This is a brand new case. And try to analyze it as you have learned. You have learned to put the outcomes of the scenario. I like to write it down. I like to write it down. And all of you know this, whoever sent to me any question before. When you send me any question, even if I have answered this question and I know the source of this question, I know this is from Andrew book, I know this from Kunji book, I know this is from med exam question bank. No, this is from our question banks. I got familiar with the question. And even so, I write down. I do like this. I get the pen, okay? For example, something like this. Okay, and I told her, okay, we have a question talking about primary. Okay, she is exhausted. Okay, she's now in the second stage because she's fully dilated. Okay, did they say anything about active stage? Yeah, she has been 30 minutes in active stage. Okay, what else? The CTG, normal, and like this. Even if I'm familiar with the question, I deal with it as a brand new question to me. Do you agree? Anyone disagree? Okay, this is the first thing that I have noticed about this exam. The second thing is new questions. New questions. A new question. Mostly from what I have in my hands now, I can see new questions are not new. They are basic questions. Apart from TOG article questions, I'm talking about the basic questions that maybe not, some of you have difficulty with it, especially the basic surgical skills, right? There was a question about granulation tissue, how to deal with a granulation tissue. This is a basic surgical question. And there was a question about post-operative complications. Who can remember any surgical questions, other surgical questions? I don't think there was anything about sutures. Yeah, I remember. Let me open the file. There was a question about Maillard incision, but this is a TOG article, so I don't count it as a new question. Can you remember any new question about surgery? Anyone? No one? Yes. The advantage of Maillard, not finished field. Okay, so what do you think about a question like granulation tissue? Was it easy or difficult? Oh, okay, yeah, maybe Joe Cohn, yeah. Yes, Joe Cohn. The granulation tissue, guys, can you remember? Was it healthy or unhealthy from the picture? It was healthy. Okay, if it was healthy, then we are dealing with something that we can leave it alone. We can just leave it alone. And in very suspicious cases where it starts to be unhealthy, like if there is areas of infection, we can apply methylene blue, healing well with secondary intentions. Okay, so we are talking about there were no option to leave it alone. Yes, then silver nitrate it is. Silver nitrate it is. Because if it's healthy, then you are going to just wait and observe. And she already took antibiotics. Okay? No, it does not need pressure cover. What do you mean by involvement of muscle? It is episiotomy, okay? Episiotomy tear or episiotomy lesion, right? And now it has granulation tissue in it instead of the suturing. It is now repaired with secondary granulation tissue, right? Yeah, whatever deep it is, I don't care. Now I have a wound with a granulation tissue filling the wound, right? My main aim now is to know whether this tissue was healthy or not. Because if it was healthy, I can leave it alone or apply silver nitrate. If not, if it's not healthy, I should remove it. Yeah, I should remove the granulation tissue, excite it, and resuture. if it's unhealthy. This is basic surgical skill. I don't know. Honestly, Dr. Mahmoud, I don't know. I didn't see the picture, so I don't know. Okay, unhealthy granulation tissue. How unhealthy granulation tissue would look like? It will look like deep red. Okay, it will look hypertrophied somehow. It can look inflamed with some pus. Okay, but if the granulation tissue was pink and with some punctuation of blood, this is very healthy, by the way. If there were no yellow tissue, there were no pus, this is very good. If it was smooth, not hypertrophied, this is very good. If it was like goosebumps, like punctuation, this is good, by the way. This is good. This means that it's about to do epithelialization. So I'm just telling you all over. Okay. Other new questions was on diacylstilbestrol. Steroid discharge can happen with healthy granulation tissue, yes. This is okay. But if it was pussy discharge, no. If it's pus, then no. Serous, yeah. Okay, diacylstilbestrol. They asked about the effect on the woman who took the diacylstilbestrol. This is a mean question, honestly. This is a mean question. Not because the question itself, because of the options. Okay, because they told me that the options were low risk, no risk, high risk of cancer, and something like this. This is a mean one. Because you might not know if there will be no risk or mild risk. Okay, as far as I know, there will be mild risk for cancer, for the one who took diacylstilbestrol back then. Okay, but honestly, I didn't search in the college resources. Okay, what other new questions do you remember? Come on, guys. We need brainstorming. Try to remember new questions.
Yes, Dr. Nada, can I talk?
Yeah, sure.
There was one patient have this one syntesinone infusion, and the sodium percent was 128, and he asked different question about stop the infusion or reduce the fluid up to 80 or reduce the fluid up to 30.
Having hyponatremia.
Hyponatremia, yes.
Hyponatremia. Okay, hyponatremia came before. This is not the first time. But you mean it was a different scenario, right?
Yes,
okay.
Yes.
We have an algorithm for hyponatremia. So to just refresh your mind, we are to hyponatremia, it's 3 categories. Okay, 130 and above 130, this is normal. And we have from 130 to 125, and below 125. Yeah. You say she was 128, so we are talking about the moderate class.
Moderate, yes. Restrict the fluid to 80.
We are not going to give any kind of solutions. We are just going to maintain the IV infusion.
Not restrict? Restricted to 80?
Restricted to 80 milliliters. Restricted as if as preeclampsia. It is the same management of preeclampsia, by the way. Renal failure with preeclampsia. Restrict the fluid intake to 80 milliliters.
Oh, okay.
And it is there. It is there in the algorithm. I just don't. I don't want to open any
اوكي
hours from us.
يا عادل
The mics,
ما وراء الكواليس.
guys. Okay. So this is okay. This is a top article. We have the algorithm. We know the resource of the question. My main problem is there was some questions that candidates don't know the resource of the question. I have here a question about recurrent candida, not chronic candida. Am I right? Recurrent candida. In
Yes,
pregnancy,
it was recurrent candida in pregnancy.
in pregnancy. Okay.
Yeah,
This
acute
is-
attack.
Yeah, this is a talk article and it's there. There is a table there talking about recurrent candida dose, the treatment dose.
Yes, there was many options, including
Of course,
clotrimazole
of course. This is
substitutes.
another thing that we are going to talk about, the time management. But I'm now trying to gather the information as much as we can, especially new questions or weird questions. As you said, this is a new
Doctor-
one, talking about hyponatremia with different details. We have time, peak blood concentration of lidocaine. Yeah, this is a basic question from part 1. Assuming no intravascular extravasation. Yeah,
دكتور ندى السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
Regarding the question of diethylstilbestrol, the option, it's not like low risk and high risk only.
What was it? Yeah,
The
yeah.
option like
tell us.
20-fold increase the risk of the cancer, 40-fold increase the risk of cancer. يعني really it's very difficult
There is
questions.
no
يعني
option like low risk or there is no risk at all.
No, it was by percentage mainly.
Oh my God.
No, it's like 20-fold,
Yes,
20-fold increase, 40-fold increase like this, which is make
Okay,
the,
oh my God, because this is a
yeah.
very old talk article, very old one. I even I don't remember. I don't remember how many folds, honestly.
Yeah.
I don't remember. But
It's
there
very
is
difficult question.
is a risk, but it's very low. It's very low.
He talked about the hazard for the grand, I mean the
Yeah, the
grand,
one who took it.
yeah.
The one who took it, not the fetus.
Adenocarcinoma.
Yeah, I know.
Uterine
Okay.
adenocarcinoma.
Okay, any new question? What do you remember? So we have recurrent candida, we have the hyponatremia, we have the time peak
And
for
that,
concentration of lidocaine. I would go for 15 to 25 minutes, but
Yes.
because
the
lidocaine
other
can
thing, Doctor,
work for like 1 hour or 1.5 hours. So the peak concentration will be the half of the total minutes of action. This is the peak.
So
Okay.
the answer should be 15 to 25, right?
Yeah, 15 to 25. Because it lasts for like 50 to 90 minutes. I may be wrong, by the way.
you
I'm telling you from what I remember.
And there was also a post-operative case.
But we are
patient-
learning now that they love to ask basic surgical questions. This is basic surgical questions. Right? Okay, what else? What surgical questions
Give me
also
back.
do you remember?
Yes,
Any
there was
easy-
one patient post-operative about 4 weeks or 6 weeks, I'm not sure. She came with dyspnea, chest pain, hemoptysis,
Yes.
and her oxygen saturation also was low.
Okay.
So
Hemoptysis.
what? Hemoptysis, yes.
Okay,
Hemoptysis, chest pain,
is a big
dyspnea.
word. Hemoptysis is a big word.
يلا باي باي.
Was she pregnant or non-pregnant? Guys,
No,
please,
she was
please, if you are not
post-operative,
participating, mute your
post-hysterectomy.
mics. She's pregnant or not?
No, she was post-operative, post-hysterectomy.
Post-hysterectomy, okay, with hemoptysis,
Dyspnea, chest
and
pain,
dyspnea, okay.
hemoptysis, and her oxygen saturation was low oxygen saturation. I think was 90.
Okay, any chronic illness?
No, nothing. She was about 46-year-old, and he didn't mention any history for diabetes or hypertension or cardiac problem.
I have here history of epigastric pain on and off. Okay, so we are talking
Yes, she was having only
maybe
epigastric
chronic
pain.
gastritis. We are talking mainly of chronic gastritis if she's not having any
Hemoptysis, not
heart
hematemesis.
problem. And you said hemoptysis,
Not hematemesis, yes,
not blood with
hemoptysis.
cough, because
No, not coffee blood,
Okay.
yes.
so I would think of ulcer. I would think of gastric ulcer.
But there was no hematemesis, there was hemoptysis with low oxygen saturation.
Yeah, so what? If she's shocked, she's going to have low oxygen saturation. But I need some history. But
This is the only
I
history that
think we are mixing two questions here, because I'm having a question talking about history of epigastric pain on and off, but she's pregnant. She was pregnant. And another question about post-operative complication. The patient, this one you are talking about, but she was having all of her manifestation was low oxygen and I don't remember chest pain. He didn't say that. No, hemoptysis was the one who is pregnant.
Okay, maybe I mistake.
Guys, you can correct me. So you can see, guys, you can see the details are conflicting. So if we are talking about someone who is having epigastric pain on and off, okay, history of gastritis, chronic gastritis, when they are going to have an operation, this is a stress. This is a stress that can cause gastric ulcer and even rupture of gastric ulcer, bleeding from the gastric ulcer. But if we are talking about other case, that she's having hemoptysis, okay, as you say, and she's having cardiac manifestation all along with the low saturation of the oxygen and so on. We are talking about congestive heart failure. It may be congestive heart failure. It will be sputum, moreover, than hemoptysis, of course, but we cannot exclude it. I will tell you what they are testing. I will tell you what they are testing. From that kind of question that you are talking about, they are not only testing your knowledge. No, guys. They are testing your knowledge and how solid your knowledge are, and how are you going to cope with the stress until the last minute of the exam. Many of you have told me that there was like 5 or more questions left, and I only have like 10 minutes or less. How many of you that happened with? How many of you face time management problems? Just say I. All of you, the time was okay?
أهلين دكتورة ندى.
Yeah.
Of course, time is not okay. Of course. Why? Because regarding the scenarios, especially in the EMQs, the distractors is weighing the question. We are familiar that the scenario, there is 2 or 3 words distracting you from the main scenario. in this exam, this not happened. يعني you will find actually two scenarios. One of them is distractor and the other is main the
Yes.
question.
Yeah.
Make you يعني confused. You will go back to read the question many times. You will come at the end of the question, then you will go to the option. You find that no, the things what this. Go again. You will go again, and you will find that the distractor weighing the question.
Yeah. Now this is
yeah,
the main reason
this
this exam is difficult. This is the main reason this
yes,
exam
this is
difficult. Not
Yeah.
about knowledge resources or new questions or whatever. I know
Yes,
what they are doing, guys. They
the
know
time
now.
Yeah.
They know now that
will be very
many
difficult.
candidates depend on recalls. They know that candidates are familiar with many topics and they think they can answer it correctly. So he's going to confuse you with many details. Confuse you with,
Yes, exactly.
like Dr. Maita saying, she's saying like you are having two scenarios. The past history has nothing to do with the current illness. Or he is saying too many details that has nothing to do with the diagnosis. Yes, yeah, I know that exactly happened before. But you know,
يعني for
inshallah, I hope that you get it right. Inshallah.
For example, the one scenarios regarding the incontinence, stress, urge incontinence for the patients after the delivery by cesarean section.
Okay.
And okay, till this phrase, we are okay. Then they came to told you that this woman, she complained of aneurysms since until 11 years. So it distracts you totally regarding the at the beginning we are familiar to okay, a bladder diary, okay, we will start for bladder retraining, then anticholinergic like this to go as we are no.
Okay,
when you give me this phrase, confuse
I'm
me.
going to tell you something. They say that she had a history in the childhood with aneurysm, then it stopped,
till
and she was okay.
till the 11
then
years.
she got pregnant, and now she's having incontinence. Now it makes sense, or there is something else?
Only
Right?
this. Then
Okay,
they give me
about the aneurysm.
the
Forget
choices.
totally about the aneurysm before at the childhood. This is distracting you. Okay. Now we are talking about someone who was really good and symptoms free for many years, and when she got pregnant, now she has incontinence. Stress or urge? This is the question. If it's stress incontinence, I would see what he wants. Does he want a total management or initial management, or he wants me to investigate her? If he wants me to investigate, I'm going to give her a bladder diary. If he wants the initial management, I would offer her pelvic floor muscle exercise. If she has mixed incontinence, I would give her both. You know, this is the problem.
Yeah, it's incontinence.
You to get lost in the details. He wants you to get lost. He knows you are going to get lost. If you are not determined, if you are not focusing, what I'm having now. I like that question. One candidate told me.
And
yeah, if you can remember, tell us.
The other question that I remember.
Sorry, I muted you by mistake. You can open your mic.
Excuse me, Dr. Nada. This question was urge mainly. There is no stress at all. Only urge incontinence, frequency, nocturia after delivery. And she has history of
this would be, if they want the initial management, this would be bladder retraining. The initial. If they want the investigation, this is another thing. But bladder diary is not our job, guys. Bladder diary is not our job. It would be the GP job. She came to you with manifestation. You know now that she had urge incontinence. Who decided this?
He asked about investigation mainly, primary investigation or initial investigation.
For this practical one?
Yes, for this case, yes.
Urge incontinence, postpartum?
Postpartum, urge incontinence, not stress. There is no any stress. All the complain about the urgency and the frequency. And she has history of aneurysms.
If this is the case, I would do a urine sample for the very beginning. I would take a urine sample and culture. But this is not what I'm having here in my hands. For this question, I have what was the initial management, not investigation. I don't know. Anyway, this is not our problem now. We are trying to analyze where we went wrong. Where could I went wrong? Is it something dealing with my focus in the exam? Did I lose my self-confidence about 1 hour later from the beginning? Because this is very important, guys. When you feel like I have answered this incorrectly, I'm not sure about this one, I'm not sure about this one. By like 10 questions like this, you are going to lose confidence and you are going to start answering haphazardly. Whatever comes to your mind, you are going to press it. This is a huge problem. To keep your focus to the last minute. And they are playing on this. They know that this will happen. They know. And I know for sure that the longest question was lost. I know for sure that this happened. The longest scenarios with the longest options were at the last of the paper. This always, this happened always. But the main problem of this exam, as I can see, is the long scenarios with mixed details. And you start to feel lost within the scenario and try to read it all over and consume time. So this is really bad. Yeah, this is really, really bad. But it has nothing to do with your knowledge, by the way. It has something to do with time management and focusing on the main part for diagnosis and omitting the unneeded history. There is sometimes unneeded history. Patient gives history of HIV positive, no records, now in labor. What should we do? We should do our HIV test now in labor. Are you sure she's now in labor? She came in labor and we don't know anything about her. No records, right?
She was hiding. She was trying to hide that she is HIV patient, but when they search in records, they find that she is HIV.
Okay, so now
And she's
now
in
she's
labor now.
HIV.
I think in
know.
second stage.
Okay, we know she's
Absolutely.
HIV, right?
Yeah.
And she is in labor. What is the first thing to do? If she's not on treatment, you should give her nevirexapine immediately. This is the answer. If he's talking about immediate management, this is the answer. If I don't know her status, I would do the test.
No, they discovered, they said that they search in the record and they find that she's HIV in her previous record.
Nevirapine was there or not?
Zidovudine was intravenous.
No, nevirapine oral.
There was no nevirapine.
Immediately.
No. There was no nevirapine. And the patient was...
I think there was, yes, an option like this, but I chose Zidovudine also. But I think there was nevirapine, yes.
I have in the records of my hand, nevirapine was there, but he don't remember if it was oral or IV. But there was nevirapine. Nevirapine.
Yes,
oral,
I think it was orally,
immediate.
Dr. Nilda.
Yes, this is the answer.
Yes, so yes, but wrongly we didn't answer this.
Okay,
yes.
let us know
But
why
this is
we
one
didn't
of
go
the
for this.
indication. this one of indication of zidovudine if the patient came in labor and you don't
Zidovudine
know.
IV, yes, but the immediate action.
Yes, this was the
Immediate
immediate
action
action.
is
Indication of
nevirapine. You know
zidovudine
why?
if the patient came in labor and you don't know about heredity. So this is one of the indication of intravenous zidovudine.
I'm going to tell you why.
Hmm.
Zidovudine IV is okay. I didn't say it's not okay, but the immediate one is nevirapine. Why? Because it's very fast. It will work within 2 hours. It will reach the baby within 2 hours.
But we'll deliver
So
her
I'm
by
not.
cesarean.
If he say immediate action or initial action, this is the right answer.
But nevirapine alone, not without cesarean section, because I think we should deliver cesarean section because we don't know the viral load.
Okay, you have pointed out a very good point. I will write it here.
Excuse me, Dr. Nada. Excuse me, regarding this question.
Yes, the doctor. Yes. Okay, go on.
Regarding this question, the patient was not in second stage. Patient was early in
She
labor
was in
and
labor,
denied.
but not in second
Was in
stage.
labor.
Yeah.
She was in
Yeah.
labor and deny first that she is HIV. Then they said she is hiding this notes because she is fearing from discrepancy. Okay, because then in the
she was afraid of discrimination, so she didn't say
discrimination.
that she is HIV. Okay.
Yes. Okay. In the choose in the في الاختيارات يعني. Okay. There was also make her test now to be sure that she is HIV positive. Because we are not knowing her status yet, okay, and reassure her.
No, wait. They said that she said I'm HIV, but I was spared of discrimination.
Yes, so
okay, I know now she is HIV.
we didn't have. Yes, but we didn't sure. We have no booking, no booking.
What would you do? What would you do in such case? We have a guideline.
Yes, but they said they searched in the record, in the previous record, and
no,
they find.
Of course, I'm not going to research. There is no record for this woman. She came in labor. What would I search for?
This is what is said in the question, that the record is showing that she is HIV.
There were no records. There were no records, guys. She is hiding it. How there will be records?
No, yes, it was written like this, Dr. Nada, in the question. They searched in the record and they found that she was HIV. Then after that, she said, yes, she is HIV, but she doesn't want to tell because she is fear of discrimination.
Yes, anyway, I know now that she is HIV positive. And this woman is not on treatment. This is what's most important. She is not on treatment.
We will not test.
How
we will
I
not
would
test
protect
her and
her and
reassure
protect
her.
the baby? How would I
So
protect
we
the
will
baby?
manage.
I would protect the baby by giving her oral nevirapine, IV zidovudine, and deliver her by CF if she is rupture of membrane. Does she have rupture of membrane?
No.
Do you know her viral load?
No, he didn't say anything about her viral load.
Okay, if I don't know her viral load, how would I know if she is willing to have vaginal delivery or not? Right? Do you agree or not? Maybe she is HIV positive, but her viral load is very low, so she can go on with vaginal delivery.
Yes, this concern, that's why we choose IV zidovudine, because in this choice they added with lower segment cesarean section. But the choice oral nevirapine, they didn't add cesarean section.
I won't ever go to choose low cesarean section. I won't ever go for this because I don't have the criteria. I don't have the criteria to choose cesarean section for this woman. What makes me choose this? I won't choose cesarean section unless they told me that the viral load is above 50. This is why the exam is difficult. This is why. If we don't have a clear concept about how to manage patients according to the Royal College, we're going to be lost. you have to choose between this and this option and this option. What would make me choose IV zidovudine with low cesarean section when I don't know the viral load? Just like the previous exam, there was a question about arrhythmia. No, not arrhythmia. Acute infarction. There was a question about acute infarction, and they gave a lot of options between vaginal delivery with instrumental delivery, vaginal delivery alone, spontaneous delivery, cesarean section. You are going to give epidural? No, you are not going to give epidural. I asked the candidates. Very simple question. Was this patient in labor? They say no. Okay. How would you know? How would you know if she's going to deliver vaginally or cesarean section? Why would you choose an option with vaginal or cesarean section? Why would you do this if you don't know? The second thing is, if you are going to choose vaginal, then you are going to choose epidural and instrumental delivery, because this will make the labor easier for her because she is a cardiac patient. Then yes, okay. But if she's not in labor and I'm going to wait for 2 to 3 weeks, how would you know the route of labor? How would you know this? See, when you see the options in the exam, I know I'm talking with relief because I'm not in the exam. But I know when you are in the exam, you are just thinking the way that, let's say, the flashback of the summaries, or the flashback of the material, or the flashback of the guideline. You don't focus on the details of the question. You just focus on, I know that IV zidovudine is giving in labor, so I'm going to choose it. Am I right or wrong, guys? Talk to me.
Yes, you are right.
I'm
That's
going
why
to
we missed a
discuss
lot of questions by silly answers. We know what to do, but confused, really.
the stress, the stress effect. This is the stress effect. So don't regret it. This is the stress effect. Don't ever regret it. You are learning how to cope with it and manage it.
Yes,
By the
Dr.
way,
Nada. And on what basis you will deliver her normal? Like
if
you
the
said, what
viral
basis you
load
will
is
deliver?
less
She will
than
deliver.
50,
There is no viral load. There is one nothing. But there is
then
all
how I
different
would
mode
know?
of delivery,
Then how I
normal or
would know?
cesarean.
How I would know? Why
Yes,
would you choose
this is my
cesarean
question
section
to you. Why you choose normal delivery? On what base?
if I choose normal delivery?
Yes, on what
I
base you will
want to
choose
choose
normal
normal
delivery?
delivery. I want to
All
choose
the
any
choices
options that
contain
have
delivery
normal delivery
methods.
or cesarean section.
No, there was no like this choices. The
There
choices
was,
include medication
okay,
with
tell me
normal
one
or
thing.
medication with cesarean.
Okay, tell me one thing. There was an option for IV zidovudine alone or nevirapine alone.
No,
Just nevirapine or IV zidovudine alone.
I don't think so. All the answers included mode of delivery with the medication. And the
Okay,
mode of
but
delivery
what
otherwise
I'm
No,
having
normal.
here
I
that
think the
there was
option
nevirapine alone.
nevirapine was alone. I
Nevirapine
think
was
it was
alone.
alone.
Yes.
Was alone?
Yes, I
Yeah.
think yes.
Mm.
Yes, it was
It's okay.
alone.
It's
Yes.
okay, guys. We are not here to correct the answers. Focus. We are here to know where we went wrong, because we don't want to do this again. Where we went wrong. I want to focus on the details of the question. I want to ask the correct question, like what I'm doing now. I'm having an HIV case, so I'm going to ask myself specific questions. What is her viral load? I don't know. Okay. Does she was on treatment or not? Because this can affect another question with PEP for the baby, right? If she's not on treatment for a specific period for 12 weeks, at least 10 weeks, sorry, for 10 weeks, regular on treatment for 10 weeks at least, then this baby is going to have PEP for 4 weeks or more. So I'm going to ask myself the right question. And this is how you should study. You should study like this. if I'm having a case with HIV and I don't know her status, what should I do? I should do HIV test to know her status. Why? Because if I don't do anything now, I will give the baby at least PEP. At least I will save this baby, right? Okay, now, no, I know her status. Alhamdulillah, I know her status. What is her status? She's positive. Okay, what is her viral load? I don't know. Then how I would know she would deliver by vaginal or cesarean section? I have no idea. I have no idea, honestly. Another question, like I told you, this acute infarction. Okay, the question about immediate action after needle prick with HIV positive case, or you don't know the status of this patient? You know the status, or you don't know?
No, we don't know. The patient was from Sub-Saharan and Asylum.
Okay. So he
And
gave
you
you the
don't know,
country.
and the ST1 break, he asked about the initial step.
Okay, so he gave you the country. He gave you the country for a purpose. He gave you the country because Sub-Saharan African is a high-risk country. And we revised it together in the night of the exam that when you have a patient who is suspicious, very highly suspicious for having HIV positive, you are going to give yourself PEP. This is the trick. And
The
love this
option was
question.
to give option was to give BEP and to confirm the risk, to assess the risk of the patient.
Okay, another good
I think
point
this
is,
was the right option.
okay,
Another option also
another
was
good, okay, another good point is
squeeze the wand.
you don't have to make sure of the status of the patient or the viral load before starting PEP. You start PEP, then you go find the status of the patient or the viral load of the patient.
But
Yes,
not
the
the
option was
initial
written
step.
like this, يعني give BEP and assess the risk of the patient.
Yeah,
It
okay.
was the option like this answer. Yes.
Yeah.
But
There
isn't
was no option
the
like this.
initial? There was option for squeeze the wand and wash it
No,
as
you
initial.
don't squeeze it. You wash it. You wash it if it's wound,
Under running water, yes.
not prick, not needed prick. If it's wound, you are going to wash it with water and soup, or
Yes.
or betadine or chlorhexidine. All of them can kill the HIV. All of them. One option was no, of course this is not true. Is to do tests for HIV, syphilis, and hepatitis, and after 3 months you are going to give the PEP? No, PEP is given first, then you can do whatever investigation you want. You know why, guys? Why? Because you have to give PEP within 72 hours of the incident, or this patient would be HIV positive. The virus is going to enter the cells and be dominant there. We are not talking about PEP now. We are going to talking about treating HIV. So I'm turning this doctor from a susceptible of HIV into a patient with HIV positive. That's why we have a criteria to start PEP. One of them is when you are suspicious that the patient you have got pricked from is coming from highly infectious area, give the PEP, take it. This is a very common question, by the way. Who can remember other new questions?
Yes, but the confusion was about the initial step. You will clean the wound and wash it by water and soap first, or you will give BEP and take basic investigation.
It's not a wound, dear. You said needle prick. Was
needle
it a
prick?
wound or
Yes.
needle prick?
No, needle prick.
Needle prick.
Not
What you are going to wash in a needle prick? There is nothing to wash. The needle prick is just a prick.
Yes.
It's not a wound.
Mm.
There was a question about endometrial carcinoma, stage 1, grade 2. Okay, of course they were talking about post operative chemotherapy and radiotherapy, right? Yeah, if it was a stage 1, grade 2, as you are saying, then it's vaginal brachytherapy. What was conflicting about this one? Okay, let me see the previous question that your colleagues wrote.
Yeah, there was also a question when to screen for sexual transmitted infections after rape. And I think the answer was
Screen for
15
what?
to 21 days. After rape, patient was raped, then went to screen for sexually transmitted infections for her. They
Yeah,
give options
this
14 to
would be
21 days.
this would be
14 to
3 to
21, I
4
think.
weeks. At least you should wait for 21 days because chlamydia is not going to be positive, Neisseria is not going to be positive after the sexual assault. You have to wait for at least 21 days. The obstetric cases, I'm really sure that we are going to waste our time if we try to recall it. This is for sure. But I want to talk to you about something. In the very last of our meeting, inshallah, I will write it here, not to forget it. Obstetric. Okay, we have some gynae cases. You say that it's new. We have subclinical hypothyroidism. We have hyperandrogenism and PCO. What was the question?
The question is which of this one, if we didn't treat, it will cause recurrent abortion back. I think the answer was subclinical hypothyroidism.
Okay, he gave you diabetes and PCO and subclinical
Yes.
hypothyroidism. And which of them, if it's not treated, it will cause recurrent miscarriages. This one is easy.
Right. Yes, hypothyroidism.
Okay. What about other gynae cases? Did you find that any of them was difficult?
There was an infertility case about male factor infertility with oligospermia. And I think it's repeated the question, the answer was ICSI, I think. For ICSI.
Can you write down the details? Okay, Dr. Mahmoud is saying why it's not diabetes. Okay, diabetes as a chronic disease, it's not going to be treated. Diabetes is not treated. Diabetes is controlled. You can only control diabetes. And diabetes is not having that relative risk with RPN like hypothyroidism. Okay, there is a whole scientific impact paper about subclinical hypothyroidism and its relation to recurrent pregnancy loss. And that's many patients are having subclinical hypothyroidism and they don't know. And that's why they are having recurrent miscarriages, and whether we should do screening for those patients or not. And the college is saying, no, don't screen those patients. Then they put a new guideline after the recent TOG article. It's not a GTG. It's not a GTG. It's a recent scientific impact paper. Yeah, a very recent one, by the way. They released it after the TOG article. And they said that those patients can be screened, but they don't need a treatment. We're not going to give them thyroxine, but we are going to screen for them. Okay, what else? The gynae question.
So, okay, and the two infertility question, I think they were clear enough and repetitive. The one I told you about male factor infertility, oligospermia, I think it was 5 million like this. And what to record for?
He has
and the
oligo or
answer-
azospermia?
I think it was oligo. I think 5 million.
Oligo and what else?
I remember.
Yeah, this
I
question,
think
I
no
hate this
other
question.
details in the question يعني was significant. Only that it was oligospermia, significant oligospermia.
Okay, can you raise your voice? It was oligospermia and what else?
In the facility. I don't remember what.
Progesterone.
The one that you mentioned in the group was this man who is having cloudy urine.
I think it's a coin. I'm on clomiphene.
No, this was another
5
question.
days.
The cloudy urine, this was another question as they are talking
6
about the
months of chronic
investigation
progesterone
for
is
this
daily
patient. A
10 to
husband
14
that
days
has the
dry
cloudy urine.
urine.
In this case, what to do? Urine culture or semen culture? This
Okay,
was
if
another question,
the
not
urine
infertility
is
question.
cloudy, so we are suspecting
Yes.
retrograde ejaculation, right?
Yes,
Right.
that's why
Okay.
urine
How would you
microscopy can
confirm
count.
retrograde ejaculation? How would you confirm it? Urine culture.
By
You are
urine
going to find the
microscopy,
sperm in the
yes.
urine.
Yes.
You are going to find the sperm in the urine. Okay.
There
I
was
have a
also
question here.
there was also one question about the male. He was healthy, and he has one child, and then started to feel weakness, and tired, easy tired, and he did FSH, LH, all was low. What you will
Okay.
do with him?
All of them were low.
Yes,
Okay. Then
and he cannot produce any semen.
Yes,
and
I
there
think
is
this question, the
azoospermic.
answer.
There is azoospermic.
No, this wasn't. He wasn't azoospermic. No, this question
cannot
was about what,
He
how
cannot
to
produce
investigate.
semen. Yes, he cannot
Yes,
produce
that's it.
semen.
Investigation,
Yes,
you mean?
yes.
Investigation. They wanted investigation.
Yes,
Yes,
what to
investigation.
investigate.
Okay, so we are having a man with fertility and he's having low FSH and LH. So
Yes,
I'm now
everything low,
thinking
and
about
he has one child before.
I'm saying this is secondary subfertility,
Yes,
right? Okay, and now he's weak. You said weak, fatigue.
weak and fatigue, and he cannot produce any semen.
Okay, okay, and the LH and FSH are high.
Low or low, hypogonadotrophic hypogonadism.
Okay, so the next step will be prolactin. You should exclude adenoma. This is the first thing that you should do. For a man or a woman, by the way, if you have a low FSH and FH.
But why
sorry.
not he took like anabolic steroid, because this is symptoms of anabolic steroid.
Where are the symptoms of anabolic steroids? You said weak and fatigue. If a man is taking anabolic steroids, he would be bulky, muscular. He would be bulky and muscular and big and look very healthy. He's not going to be weak and fatigued. This is a sign of adenoma. Adenoma is going to make you weak and fatigued and have visual disturbances.
But adenoma mainly come with headache.
No,
he was not having
no,
headache.
not mainly. No, not mainly with visual symptoms. No, there is microadenoma. There is microadenoma, guys. Microadenoma, the prolactin can reach 500.
So the answer to check the prolactin, right?
What
Not to repeat the investigation.
What about the
after 3
testosterone?
months?
I will tell you why it's not anabolic steroid.
Testosterone was normal.
That's it. That's it. If it's anabolic steroid, the testes will be weak. The factory will stop producing testosterone.
An
Right?
anabolic steroid, he will take
Yeah,
testosterone will be high,
yeah,
will be okay.
It will depress the FSH and LH, and it will depress the testis. It will cause hypogonadism. If prolactin is there, then I will go for prolactin. I'm telling you the algorithm for male infertility. Maybe I'm wrong. Maybe there is another detail in the question, but with what you are saying now, I would order prolactin to make sure that the reason why the LH and FSH are not low is not from above, from the pituitary. If it's secondary, this is another thing. If it's from the testis, I would find high testosterone, like testicular cancer, for example. The high testosterone will depress the LH and the FSH. If it's anabolic steroids, the anabolic steroids, when you take it, it's not going to affect the LH and the FSH. It's going to affect the testosterone production. Yeah, this question I hate so much. The question about what type of hypoxia according to the deceleration in the CTG. They told you the type of deceleration, or it was a picture of CTG?
It was a picture showing early decelerations, repetitive early decelerations.
Only early deceleration. There were no variable or prolonged.
No, but repetitive.
correlate?
يعني a lot of early decelerations.
All of them was early.
As I could assess, يعني, I think all of them was early.
Then what hypoxia it's going to show us? There is no hypoxia here.
يعني
think
it was first time
variable.
to me to see this.
It was
No,
variable.
I think
Yeah,
it was
there is types of hypoxia according to the CTG, but this is really very difficult one. This is really very difficult one. There
was
is
variable.
acute
I-
hypoxia, and there is
variable.
gradual
Cannot
hypoxia, and
yes,
there is
okay.
chronic hypoxia. Yeah, I know, but this is the whole subject. We know it from the continuous CTG and a type of CTG that we call I don't know the answer. I don't know the answer. I don't know what type of deceleration was there. I don't know, because there is something called recovering deceleration, like some early deceleration and some late deceleration. This is recovering deceleration is an indication of chronic or evolving hypoxia, but I don't know.
There was also another question about the best marker for the DIC in a patient. It was about fibrinogen
The best
or
one would
PT
be
or
fibrin
PTT.
degradation products, or what else was there?
Fibrinogen, prothrombin time, partial thromboprestin time. I think the answer was fibrinogen, if I'm not wrong.
Yeah, DIC is not diagnosed by PT or PTT or INR. Yes, fibrinogen or fibrin degradation products. Yeah, this is somehow, I'm not going to say new, but it's very basic, like part 1 question. But
Another basic question
I'm going
also
to
that
send
we
you something
cannot
about CTG. And this
Mhm.
CTG questions, we are going to consider it from like the 1 or 2% of questions that nobody will answer correctly. That's okay. But I'm talking about the cases now. The gynae cases, because they send me cases very conflicting. It's very conflicting.
There was a question about patient came with condyloma, lesion, primary lesion of syphilis, but
Okay.
all her lab are negative. Tabba was negative, Elia was negative, and also RBR was negative. All negative.
Okay, and she's having an ulcer.
Yes, she have like ulcer of syphilis.
The ulcer is painless or painful?
Painless ulcer.
Painless.
Painless ulcer. For how
A
long?
description of condyloma.
For how long?
Didn't
I think
mention.
they didn't tell for how long, but the question was about how to interpret the tests. Yani the
2
options
days.
was false
Dr.
negative
Mahmoud is
test,
telling us
false
2 days. I was
positive.
waiting for this. I was waiting for this. Dr. Mahmoud is saying history of the ulcer was only 2 days. It appeared 2 days ago, right? Okay, and all
Yes,
the
I
tests
think
are
right.
negative, right?
Yes.
Of course, all the tests
Yes, right.
would be negative because syphilis took time to appear in the immunology test.
So the answer
could
is
be
false negative
primary
because there was
syphilis.
no answer. There was no an answer of early syphilis. So
No
false
primary
negative is
syphilis?
accepted or not? No answer was like this, I think.
There were
I
no
think,
primary
all-
syphilis in the options. I don't know the answer. If there is no primary lesion or primary syphilis within the options, then I don't know the correct answer, honestly.
There was
So
primary,
false
but they were
negative
not
cannot be
early.
accepted.
Yeah, primary syphilis. 2 days
Sorry,
ago, only 2 days ago. Only 2 days ago
Dr.
would be
Madam.
primary syphilis, and it does not appear in the test.
There was the primary syphilis course. There was confusing as by both boson phenomena and the false negative, but the history of ulcer only 2 days. So it is the primary syphilis.
Yeah, this is a primary syphilis, guys. This woman has syphilis, okay, but it's very early to appear in the immunology or serology test. The prozone phenomena. Prozone phenomena is a very different thing. Prozone phenomena is when you have a case of syphilis before, and now the non-treponemal tests are negative.
Primary syphilis was the last option in this question.
Okay, so prozone phenomena, to clear it for Dr. Mahmoud, prozone phenomena is when you have a chronic infection. It's a chronic infection, okay? So some of the tests will be positive and some of them would be negative. The one that
There was
would be
another
positive,
question already.
the TPPA, whenever you have syphilis, you are always going to have TPPA positive. Okay, the RPR is the one who can be positive one day and now it become negative. This is the prozone phenomenon. I think there was another question of syphilis. Oh, syphilis always come in the exam.
Yes, it was another question where RPR is positive and all. So
Yeah.
what
Okay.
was the answer
The
for this
options.
question?
The options were
And
what?
this patient has what are positive and all other markers are negative. I answered prozone, but I don't think it's right. When I found autoimmune disease, I answered prozone.
Okay, she
I don't
have
know.
RPR positive only, and
Yes,
the
RPR positive only.
EIA
Only positive.
negative and TPPA negative.
Yes, I think yes. I think it was only two TBLA and EIA. I think the other
Okay,
markers.
so
Yeah, two negative,
see
RBR
here.
positive.
Dr. Maya is telling
Mm.
us one very important detail. Very important detail. The patient was having rheumatoid arthritis and she is on medication. So that's why the RPR is positive. That's why she's
Yes.
having RPR positive.
So it is
Okay,
the
there
answer.
was biological false positive or only false
Prozone?
positive?
Prozone phenomena is accepted here?
No, she's not chronic. If she's chronic, the TPPA would be positive.
Hello, Dr. Nada.
Hello, Dr. Pamideli. How
Yeah,
are you?
the question on prozone is quite different. I think the last speaker is mixing it up. The question of prozone is clear. This particular one, the confusion was between false positive or biological false positive. She's a patient with rheumatoid arthritis on medication. So we're confused between false positive or biological false positive. Thank you.
Okay, there was two options. One of them is false serology positive and the other biological false positive. Right? Am I right?
Yes. The question on prozone is different. That one is
yes.
different.
Okay,
This particular one, the answer is between these two. Yeah.
I got it now. So, okay, so you are conflicting between whether it's biological false positive or serological false positive, right?
Yes, doc. Yes. Yeah.
Was she pregnant?
No, she's not pregnant. She's having rheumatoid arthritis on medication.
Okay, I would go
now
for
RPR is positive, all other ones are negative. So
I would go for
the confusion was between these two. The confusion was between false positive or biological false positive.
Yeah, this one is tricky. This one is tricky because now you are dealing with the name of the test, or how would you call it? I would go for serologically false positive. if she's not pregnant, specifically if she's not pregnant. But anyway, this one is also very, very cruel one, because he's not testing your information, he's testing whether you are familiar with the name of the testis or not. Okay.
Okay, there was another question
Another-
about the mode of action of tranexamic acid. To convert fibrinogen to fibrin or prothrombin to
Plasminogen
thrombin.
to
This
plasmin.
one is a
Yes.
very old recall.
Inhibit plasminogen to plasmin.
This is
There
a
was
very
one
old
question
recall.
about a young girl, 6-year-old.
Okay.
She came with her mother. She came with itching and dysuria. And
Dysuria.
there was excoriation around the vagina, and there was grayish discharge.
Greenish discharge. Okay, green discharge
Greenish,
equal
greenish.
STD. STD. This, we are now talking about an STD. Why this girl is having STD? Was there any signs of assault or not?
No, this is the scenario, not mention anything.
On the examination?
I'm not sure greenish or gray.
Green, the green
Sorry,
discharge.
Dr. Nada, in this question, I remember they told that this baby was يعني 6 years old, was continent, and again she has incontinent. So in the scenario, like after that, she's complaining of greenish discharge and this one red exenteration. I think the meaning STD because يعني
is an
or
STD
assault,
for sure.
sexual assault, because يعني this child is frightened from to go to toilet. So it is, I think this is sexual assault.
This one important detail is really good. The
Yes.
child now is having a fear to go to the bathroom. She was continent, but now she is incontinent, right? She's having green discharge and dysuria. This is STD, guys. There is huge suspicion for sexual assault. Huge suspicion. For sure, even if I'm not talking now about sexual assault, green discharge is not bacterial. I was really feeling very low when I see guys on the group saying that green discharge is bacterial. It's not bacterial. This is trichomonas. Trichomonas is the commonest STD within children. Am I right or wrong? Maybe you know something I don't know.
Yes, scenario like this, Dr. Nada, like this scenario, they mean sexual assault only.
Even if they said that she has itching at night, he's confusing you, because worms are not going to call this girl green discharge. Green discharge with bad odor or smelly odor or fishy odor, all of those are trichomonas. All of those are trichomonas. Bacteria is not going to give her green discharge. Green discharge is something really, really significant. If a mother notices it, then this is a great significance. Okay, and you say that she was afraid to go to the bathroom and she was continent and now incontinence. All of those are like post-traumatic experience. Anyway, okay, I have a question here, gynecological one, talking about amenorrhea. You had cases of amenorrhea. I'm not sure if there was 2 or more cases.
Yes, there was
Dr.
one
Maya,
patient.
foreign body is not going to cause green discharge. Foreign body is going to cause bacterial vaginosis. Bacterial vaginosis is going to cause copious amount of vaginal discharge, yellow or white, with fishy odor. The green discharge means STD. This is very significant for trichomonas. Okay, the gynae cases, because I got really difficult gynae cases in my hands.
There was one patient.
I want to make sure that it was really difficult, or maybe the one who
No,
recalled consider it
there
difficult.
was one patient. She's 18-year-old and she's amenorrheic with secondary sexual characters, well developed breast and pubic hair well developed, and I don't remember the vagina was dimple.
The vagina, the investigation, all investigations are normal,
Yes,
even the
secondary
vaginal
sexual.
examination.
He just said yes. He just after examination, the vagina was blind-ended or dimple. I'm not sure. And she has cyclical pain. Yes, this one I think MRCOG.
Cyclical abdominal pain.
No, this cyclic pain was another case. This case that has dimple vagina, they are confusing between complete androgen insensitivity syndrome or partial androgen insensitivity syndrome. The other question was about cyclic pain, but with examination you cannot notice anything. This was for transverse vaginal septum. These are two questions separate, not the same question.
Allah. You guys always never fail to surprise me. Wallahi. When I get recall questions, I get, mashallah, different scenarios. So we can have like 500 questions from our discussion, not only 200. So I'm having a patient who have features of transverse septum, and another one Mayer syndrome, and the third one maybe she's having AIS. The one with AIS, everything would be normal? No, not everything would be normal. She's not going to have everything normal. She's only going to have normal breasts, right? But she's not going to have normal vagina. For AIS, I'm talking in general. AIS, it's partial or complete. She's not going to have normal secondary sexual characters. And the partial one is very, very difficult to diagnose from just examination. We need tests. We need a test. Those girls is going to have normal life as a female, and suddenly she's going to discover that why I'm not having periods like other girls. Okay, and they would treat her like PCO, but she's not PCO. This is partial AIS. They didn't mention anything on local examination. Okay, in the okay, this is a good question. Why for a Mayer girl would have cyclic pain? Because she's having ovary. She's having ovaries. And she could have ovulation pain. That's why she can have cyclic pain. But the transverse septum, it would be evident in the examination, guys. If he said examination is normal, this is not a transverse septum. TFS, what is TFS? Turner or what? I'm not getting it. The case of high estradiol, yeah, this one. I want you to correct me if I'm wrong, because I'm having here a case of, let me, I will write it down. Testicular feminization syndromes, there are so many. There are so many. Why would they have high estradiol? No.
Sorry, Dr. Nada.
I will write down what I have here.
There was two questions, of course, about MRK, but this question, of course, it was cyclic. She has cyclic pain and normal secondary sexual character and dimple in vagina. So it was the MRK, not
Yeah,
the
yeah, Mayor,
they
this is
doing
what
transverse
Mayor.
septum because they do as transverse septum because of cyclic pain, but 10% of this America they have rudimentary horn, so they have in the function endometrium and they have cyclic pain also.
Yeah, because they have
So it
ovaries.
is,
Even if she had absent uterus, if we
yes,
suspect
and
that
he told this patient she has this cyclic pain for 2-3 years. If it is transverse septums, it will collect and it will lead to abdominal mass. This was a key in this question, of course.
okay, for sure, this is a fact that Mayor girls can have cyclic pain, rudimentary uterus, or because of the presence of ovaries, she's going to have cyclic pain. Not all of them, because some girls pain thresholds are very high. But for some other girls, she can have cyclic pain. I'm having a case here, and I want you to complete it. The one girl with amenorrhea, high estradiol, high prolactin, high normal FSH and LH, normal testosterone, and I think normal DHEA. Is that right? What am I
Yeah,
This was
examination?
this was secondary
was-
amenorrhea. This one secondary amenorrhea. I think she has
Secondary, not
3
primary?
children. No, not secondary. She has 2 children, something like that, and she came complain of hirsutism and amenorrhea also. And
there was one case of hyperandrogenism. Yes.
Nortestosterone.
Yes.
No. This is another case. I'm not talking about this one. I know this one. I'm having it here. We have a case of hyperandrogenism. Yes. Okay, with high 17 hydroxyprogesterone.
Yes.
This one, right? Am I right? The hyperandrogenism was high 17 hydroxyprogesterone and testosterone 3, I think, or 4, something, but it's less than 5.
لا testosterone I think it was high, was 5.
Oh, that's better. That's much better. Now I can say my answer with a relief. This is much better. Okay. But
Yes,
the other one I want to remember, the high estradiol with high prolactin, and there was high normal FSH and LH, and the other test was normal, the testosterone and the HEA. What was the examination?
Yes, this vision.
Oh yeah,
Yeah,
yeah. It's written here. No hearing symptoms or difficulties. And
yes. Also, it was tall. 170
yeah,
cm.
170 centimeter and 55 kilograms.
Yeah.
This is the
I
same
didn't
case?
remember. Yes, I think 55. I think.
Yeah. He writes here that she does not have galactosemia because there is no hearing symptoms or visual symptoms or anosmia. So they excluded galactosemia and they excluded Kalman.
Yeah. They exclude Turner.
In this case?
They exclude Turner syndrome also.
How they excluded Turner? Because the toll. Oh, okay. She's told. So this is correct. This is correct. Do you agree, guys, of this case? The tone one. Everything here is right. What do you think this girl is?
Is this only they write only this table of her investigation and this information that no hearing, no any skeletal symptoms or anything.
Yes.
This
okay.
is yeah.
That's good. Okay, so we have a complete case now. This is a primary amenorrhea with no hearing symptoms and no visual symptoms, and there is no.
And she was also age is important as it was 18 years old.
She was 18. Okay. Good. And she's tall and she's thin. And the options was a broad types of syndromes. Right? Mayor was there? Mayor syndrome was there?
Yes. Merka was there.
Okay, what about the examination? Did they say anything about examination?
No examination given, only investigation.
Are you sure?
Yes,
Because
sure.
we have broad
sure.
differential diagnosis here.
No, they only
This
give
case,
this
guys,
one.
this case was high
I didn't
estradiol and
remember
high
they get
prolactin.
blind in the vagina or no. I didn't remember. Yani, for me, I didn't remember. If anybody remember that.
Okay. Dr. Ahmed said that they said the investigation was normal. So can you remember any? Because this case now with this what I'm having here could be many things. Could be many things. Really. So I don't know. Specifically when she's very tall like this, I would think of LH luteinizing defect. But he's very sure that the estradiol was high and there were no LH defect within the options. There was Nelson syndrome, X syndrome X, Prader-Willi, PCO. What else? Very bad handwriting. Let me see. I have written it somewhere. If you can add something, tell me. I need the examination. The examination would be very helpful. If you had vaginal examination or the sexual characters, it would be very, very helpful. Anyone can remember? No one?
Sexual character, they told it is well developed, I think. Well developed sexual character.
Well developed. Okay. High estradiol and high prolactin make me think of ovarian cancer or ovarian tumor. But why she's having high normal FSH and LH? Something is not correct here. This high estradiol should have some pressure on the pituitary.
Prolactin was not high. Prolactin was not high.
Prolactin was
it was fine. It was, I think, in the normal range, 500 something. It is not high.
But the FSH and the LH was high or normal?
Normal also.
Also normal?
Yes.
So only high estradiol. I would think of Mayer. If you are saying everything was normal.
It is going with Mecca. Yes, it is going with Mecca.
Anyway, we're not sure, but really what I have been given make me very conflicted. Like why there would be normal high FSH and LH. This would go with premature ovarian insufficiency. But again, there was high estradiol, and you all agree with high estradiol over 500, right? The prolactin, we have different opinions. Some say it was not high, some others say no, it was high. But we agree on that she was tall and she was thin. Why this wouldn't be something like hypogonadotropic hypogonadism of weight because of her weight? Because I need the FSH and the LH. I need them. If they are low, then this is because of her weight. This would be perfect case of weight hypogonadism. primary amenorrhea because of her weight. But if the FSH LH was normal, no, this had nothing to do with her weight. Okay. Anyway, can you remember any new questions? Other new questions?
Normal FSH and LH.
They give you the reference, but we
And
are
I think
when
FH19.
they give you FSH LH more than 30, this is POI or premature ovarian insufficiency. But it's not even 20s. He said it was like 18, 17, something like this.
Dr. Nada?
Yes.
The LH is 19. It's not going with BCOs.
This case is a PCO.
Yes.
Is there any signs of hyperandrogenism?
I think I don't really.
Okay, first of all, to diagnose PCO in such thin patients is very rare and very difficult. Because PCO patients usually have insulin resistance. She's not going to be like this thin. She's underweight.
Yeah.
This one is underweight. She's 170 and 55 kilograms.
Yes, yes. The LH is 19 and I think FSH 7 point something.
Okay, so she's having inverted ratio also.
Yes.
Wow. You are making it more difficult. But you know,
and
if this is
and
true,
estradiol, I think it was 300 something or 500 like
if
that.
this is true, guys, this would be a perfect case for LH defect receptors. But there was, he said there was no LH defect receptor. And
no, and
I
also
honestly don't know. And I honestly don't know the answer.
and also I think Swyer syndrome also was not in
Yeah,
in
and Swyer
options.
syndrome was not there. Yes. Okay,
and
this one would be like I'm going to find out what it is. I'm going to find out.
And I think also this because they write also they distract also this word that no hearing loss, no skeletal, because some of America they have hearing loss and skeletal abnormalities.
Exactly.
Some of them not all. So I think they distract us, but this is I think America. I don't know actually what is that.
Maybe it's Mayer. Maybe it's just Mayer. Maybe it's just Mayer. And Mayer can have a high estradiol if the ovaries is having a tumor, and they are very prone to have tumors in the ovary. So maybe. Okay, I have a new question also about assessed in a premenopausal woman with ground hour appearance in the ultrasound, and it's a simple test with ground hour appearance, and the CA 125 was high, but less than 200. Is that true? Do you remember this question?
Again, ma'am, again, please, Dr. Nada.
Premenopausal cyst with ground hour appearance in the ultrasound, and it was a simple lining cyst, and the CA 125 was high but less than 200.
Yes, I think this question they're asking about tumor markers. They give us many choices for tumor markers when they give us.
No, not this one was the tumor marker. Another one for post-menopausal one was for tumor marker. This one, he answered that they. I'm not sure what was the next step or the best management. Are you going to refer her to the oncology clinic, or you are going to do an MDT, or you are going to do a cystectomy, right? Yes, thank you, Dr. Abir. So you are confirming what I'm having. Yes, this is an endometrioma, guys. This is endometrioma, the ground glass appearance, ground hourglass appearance with simple lining. This is an endometrioma, and that's why the CA125 is high. You know that CA125 is not specific. It can be raised in endometrioma. So the best management for this case, if it's doing symptoms, I'm not sure if it was doing symptoms or not. If she is symptomatic and this test is more than 3 centimeters, the best answer would be cystectomy. Laparoscopic, of course, if it was there. I like this question. I like it so much. The other question you are talking about the tumor markers.
The easiest. This is the easiest question in the exam, I think.
Alhamdulillah. Alhamdulillah. Okay, let me see. Okay, I got another one post-operative thing, but the question with the tumor marker, I think it was an easy one. It was post-menopausal, right, with suspicious test, and they ask you about what tumor markers you should order or something like this. Renal abnormality associated with uterine anomalies. The most common one is renal agenesis.
The picture was Didelphi.
I don't know that there was a picture. Oh my God.
Yes, there was a picture and it was Didelphi uterus.
Okay,
and
generally speaking, the most common renal abnormalities with uterine anomalies is renal agenesis. This is the most common one. They gave you a didelphys, they gave you septate uterus, whatever, any uterine anomalies. The most common one is renal agenesis, as mentioned in the scientific impact paper for uterine anomalies. Tumor marker for premenopausal, if she's premenopausal, the test was complex or simple?
It was complex.
Complex, then we are going to choose CA125, and we are going to choose the HPG, and we are going to choose the inhibin, LDH plus or minus. Okay, I have a question here. A patient who has left hypochondrial pain radiating to shoulder. She's pyrexic, she's tachycardic, and the examination shows solid percussion in the left lower lung and tenderness. And the X-ray show shadowing over the lower lobe of the left lung. Can anyone remember any further details? Because this question is also new. I haven't seen it in the recalls before, but I haven't seen it in books. Stony dullness.
This question, Dr. Nada, I remember this question also was actually very very difficult question.
Okay, 8 minutes. Sorry, 1 minute. 1 minute. Dr. Abir, the history of chorioamnionitis, I think it's another question. Or the
same question.
The same question,
the same one. Okay.
Yes,
so we have
the patient have a history of
chorioamnionitis. This is the source of infection. Okay. Let's
she has
one by one.
For chorioamnionitis.
Stony dullness over the left lower lobe, right? And the X-rays showing shadowing in the left lower lobe also. Okay, and there is a left hypochondrial pain radiating to the shoulder. Is this true or not?
The right only stony hard dull percussion over the left base over the base of the left lung.
Okay, he remembered that there was left hypochondrial pain radiating to the shoulder. Okay, what
there was right hypochondrial pain on percussion. There was stony dullness on the left, the base of left lung. After cesarean, the patient was going for emergency cesarean for acute chorioamnionitis. Then she came after 5 days, I think, with this dullness, percussion, and fever.
Okay. So we have a source of infection.
Cough
And we
also,
have a
doctor.
stony dullness.
came with
We
cough.
don't have to forget about the stony dullness. Stony dullness over the lower left lung. I would think of many things. I would think of sorry. You said post-operative 5 days. Okay, so it's an infection. It's an infection, but she had a complaint of cough. You're making it difficult now, Dr. Myself. I was just reaching the diagnosis.
I think cough was another patient. This is not with cough. This patient was
Shoulder
not
tip
cough.
pain, guys. Shoulder
No,
tip
no,
pain.
no.
This is
The same
something is
patient.
related to
I
The
think
same
the other
patient.
patient was cough.
No, this patient,
we
she
are
came
talking
with
about
cough.
the diaphragm
I'm sure.
here. We are talking about the diaphragm here. If you are having a pain and it's referring to the shoulder, mainly in this particular point, if it's hypochondrial pain radiating to the shoulder, we are talking about kind of something is wrong with the diaphragm or around the diaphragm at least. Okay, there was subphrenic abscess. Subphrenic abscess, you said? Okay, it goes with the scenario, because subphrenic abscess is going to cause the shadowing. It's going to cause the dullness with percussion. Okay, because I was thinking about other differential diagnoses like fluid in the pericardium or effusion around the lung. That's what can cause dullness with percussion. But you say solid percussion. Solid percussion, that means a mass. If solid percussion was there, this is a mass. So yeah, I would go for subphrenic abscess if it's there, with pyrexia and the pain referring to the shoulders and everything, and a history of cardioamnionitis also, more than pneumonitis. Pneumonitis or pneumonia, it will be, first of all, it's not going to be in the lower lobe. Okay, and if it causes pleural effusion, if we suspect, or let's say it's complicated with pleural effusion. Pleural effusion is not solid dullness. Okay, and it's not going to be unilateral. Yes, it's not going to be unilateral. No crepitations, okay, and yeah, I saw Dr. Malengi in Dr. Conji's book, but I don't remember a recall like this. Okay, let me see another question. We have some TOG article questions I'm going to discuss with you, but they are not hard. We have some basic questions like risk of recurrence of Down syndrome in a mother who have a previous baby with Down syndrome. This one is not difficult.
Dr.
Ultrasound, fibroids. Yeah, fibroids. Yes, you have a question about cervical fibroids, but I don't know the options. Yes, they told me about cervical fibroids. 8 centimeter cervical fibroid, and it was causing dyspareunia and pelvic pain.
Yes,
Right?
pelvic pain, urgency, frequency, pressure
Pressure
symptom only,
symptoms.
cervical
causes pressure
fibroid,
symptoms.
HCM.
Okay, great. So we are having a pressure symptoms and cervical fibroid. Now, the cervical fibroid is very big, actually, it's 8 centimeters. Hysteroscopic resection. You cannot remove a cervical fibroid with hysteroscopy.
The options, Dr. Anada, the options is myomectomy and laparoscopy, hysteroscopic resection, total abdominal hysterectomy. And
Okay, so now we need more
I think
details. We need more details. We need the age of the patient.
she's
her wishes
45
to
year old.
conceive.
45-year-old.
Okay, does she completed her family?
I think no about this thing mentioned.
No, she told she doesn't want to get pregnant again.
Okay.
Yeah.
Age is 45. I think they didn't mention about her fertility option. She needs fertility or no, they didn't mention.
Okay. Because I'm thinking of myomectomy, but what kind of myomectomy they mentioned, because you are having, mashallah, different options. Like there is laparoscopic, there is
myomectomy, the options.
laparotomy, there is endoscopic.
Dr. Nada, no myomectomy in the options. I searched much about for it, and I didn't found no myomectomy in the options.
No
Rather
myomectomy.
abdominal or
There
vaginal.
is myomectomy. No, there is myomectomy and I choose it.
I
There
think there was the hysterectomy, abdominal or vaginal, uterine artery embolization. Other option.
Uterine artery embolization is not going to be the answer, of course, because this is a cervical fibroid. And it's not going to be affected so much when you occlude the uterine arteries. Okay, now we are talking about myomectomy or hysterectomy.
There was abdominal, there was, I think, laparoscopic or abdominal hysterectomy, I think.
This one is really bad also, because you know why? Because the recent articles about fibroid is not talking too much about cervical fibroid. They are not talking too much about.
The issue in this question, the issue is two things. HCM, they should give GnRH an option and no GnRH given at all. I searched also for GnRH, I didn't find.
Great.
The other thing, if we are going to do in this big fibroid without giving any GnRH to do this one hysterectomy, it will very difficult to get this one without injury to other organs. So for me, I choose the uterine artery embolization. I don't know if it's true or no, but this is the safest option for the patient.
Okay, I'm thinking now exam-wise. Why? Because when the examiner is putting a question, he should rely on a resource. This is one of the rules of putting a question. He should rely on a resource, and that's why I'm thinking, what is the resource of this question? The top article talking about fibroid does not mention any details about cervical fibroid in particular, but they mention many details about uterine fibroid. This is one. Number two,
the issue that
a very big cervical fibroid.
We want only to shrink this fibroid so patient can improve her pressure symptoms. The issue that one.
And it's causing pressure symptoms, so you need to remove it for sure. For sure, you need to remove it. Okay, but the route for removal, it's going to depend on many things, many other things. And you say that she is 45. Okay. She has no fertility wishes. Fine. Myomectomy will carry many risks for injury. because the position of the fibroid and the size of the fibroid. Vaginal or abdominal. Vaginal hysterectomy with this size of fibroid is going to be very difficult. But again, I'm answering from my information. I'm not answering according to the Royal College, and this is something that bothered me. This is what
I searched for GnRH and hysterectomy. I didn't found, so I didn't choose to do hysterectomy with this big fibroid without shrinkage. Of course, maybe uterine embolization is wrong, but also I don't know actually what is the best answer here. They told what is the safest option for the patient.
Okay, we have two questions to try to know what they are. This one and the other one was with the primary amenorrhea, the tall girl. There was an option for morcellation before vaginal hysterectomy, because if it's there, this would be a really good answer. If there was option about morcellation before vaginal hysterectomy or morcellation with vaginal hysterectomy, yes, of course, it would be brilliant answer. Was it there? You said no. Okay, if I were you, I would think that myomectomy would carry very high risk of injuries to the bladder and the arteries. I would do a total hysterectomy, but the route, generally speaking, abdominal, not laparoscopic, of course. But by the way, laparoscopic can be done for this case. In expert hands, they can do it. Yeah, very high risk of hemorrhage if we do myomectomy also. Okay, let's see the exam resources quickly. In very, very good hands, very expert hands.
In such a big fibroid, morcellation.
They are going to do morcellation before laparoscopic removal in the retrieval bag.
But it is.
But it's not the first option, of course. No, it's not the first option. Not the first option.
In big fibroid, because it is a high risk for leiomyosarcoma also. It is not recommended as management for fibroid now.
Yeah. Okay, let's see, or let's review what kinds of guidelines have appeared in this exam. Cholestasis, right? Let's go obstetric first. We have cholestasis. We have breach. I don't know the past percentage. Nobody will know it, by the way. Instrumented delivery. Okay. What else? Anything about perineal tear? Yes, this is nice guideline. Intrapartum care is a nice guideline. I'm talking about the GTG. FGR. Yes, very good questions about FGR. VTE. Malaria. Twins. What else? Sickle cell, thalassemia. Okay, sickle cell. FGM. If you are counting, I'm about to reach 10 guidelines. Cerclage, okay, we have reached 10 guidelines. Okay, so we are talking about hot topics. Nothing new. Even if the question is twisted or having an idea, incontinence is nice guideline.
There is also, Dr. Anna, question about aneuploidy screening for twin pregnancy. One of them is a vanishing twin.
This is
At,
nice. This is nice
booking.
also. This is nice also. Recurrent
Yeah.
miscarriage. Okay, now we are talking about scientific impact paper. We have recurrent miscarriages. Anything about abortion? Doses of abortion? Because this is best practice paper. Abortion. Pancreatitis is a top article. Causes of abortion, okay. VTE, I'm sure they brought a lot of VTE questions, I'm sure. And one of them was really a good one, but there was a postpartum VTE risk assessment for someone who is 30 years hypertension induced forceps delivery, PMI 35. I have this question here. I don't think it's difficult, but I always have something to do incorrectly when I calculate the score. So what was it okay for you? It was not difficult for you? The VTE questions? Okay, so we have guidelines, of course. We have scientific impact paper because we talked about uterine anomalies and we talked about recurrent RPL with hypothyroidism. Yes, I'm asking you about best practice paper, abortion, the doses of abortion or anything like this. Okay, so it didn't come. Nice guideline, of course, you are having intrapartum care. Labor. Yes, urinary incontinence, fertility, of course. Okay, TOG articles. I have counted the TOG articles, but they are not very new like the previous exam. In January exam, they brought a lot of new TOG articles. This exam has like VTE in gynecology surgery, right? As a new one, I'm talking about the new TOG article. And I knew it will come. I knew it will come. Can you remember the case of this one? Because it's going to be, they are going to bring it all over. You are going to repeat this question, guys. They are going to repeat the TOG article, talking about thromboprophylaxis in gynecology operation. Can you remember the case? Was it cancer case or normal gynecology case? Not cancer, okay.
Dr. Anada, it's a patient post ectopic. I think salpingectomy or salpingectomy, like this, mild laparoscopic.
It's not cancer, because cancer case would go for thromboprophylaxis directly. Any cancer case is going to have a score that make her needing to have thromboprophylaxis. Okay, she's not cancer. You are saying she's having more than 4 risk factors. Can you tell us the 4 risk factors?
4 risk factors.
Was she obese?
I don't know, like
smoker?
I don't remember. Maybe smoker. I don't know. really.
BMI, the age. Does she have any chronic illness?
No, I didn't remember. No, there is no risk factor.
In the group, one of your colleagues said that she was a smoker and she has BMI over 30, but her age was below 30, like 25, 27, something like this.
Mm.
Oh, yeah, they told me that she had intraoperative hemorrhage, but she didn't need a blood transfusion, or they don't remember that they needed blood transfusion.
Yeah. Yes. Yeah, she lose 1,500 during operation.
But no
Yes.
transfusion mentioned.
No, they didn't mention.
Okay, so she is a smoker and bleeded. I don't care about bleeding. If she has blood transfusion, she's going to take a score of 1. Just bleeding, it's not going to affect us our score. So she's having like 2 risk factors or something like this. If she's having a score more than 1, she's going to need something. It's not going to be ambulation alone. That's what I wanna say. Yeah. No, this one.
Yes, and one of the
You
one
are
of the
going
options,
to use this score.
give low molecular weight. Why?
Score. This one is adapted from Caprini's score.
Paper. Technical vision. Paper.
So anyway, you know now that this talk article is very important. So I'm not sure of the risk factors. We need to calculate the risk factors. If she's moderate risk, we are going to go for mechanical thromboprophylaxis only. If she's high risk, she's going to have both mechanical and pharmacological, as we discussed before in the talk article discussion. Okay, if she's having highest risk, her risk score is more than 9, then she's going to need the low molecular weight heparin for 30 days. Okay, gestational hypertension without chronic hypertension takes score 1 for DTE. You mean for DTE assessment in pregnancy? Yes, dear. Yes, this question is talking about post-operative prophylaxis for whom? For someone who had an operation. Not labor. This is not labor. An operation, guys, for ectopic pregnancy is not obstetric risk. You have here, see, this is early pregnancy management. So you are having either miscarriage or ectopic pregnancy. You should know if she's having personal history of VTE or not. Because if she's having personal history of VTE, she is for sure going to need thromboprophylaxis, for sure. You are not going to calculate any score. But if she does not have any personal history of VTE, you are going to calculate her score. If it's more than 4 or more, then she's going to need something. She's going to need low molecular weight plus mechanical. If she's less than 4, she's going to need mechanical during hospitalization.
বের হচ্ছে আচ্ছা তো
So I don't know the score.
হুম
Okay, this is one of the top articles that appear in the exam. Another top article that is considered to be new and appeared in the exam. Let's get back. I'll get back to my notes. If you remember, you can tell me. We have hyponatremia. It's not really old. We have diabetic ketoacidosis, right? You get diabetic ketoacidosis. Anything for postpartum urinary retention? I didn't get a question about urinary retention postpartum. Okay. Anything for cardiac diseases? No. Yes. Yes or no? Arrhythmia or acute ischemia or peripartum cardiomyopathy. There was a question about doxorubicin, right? And what should you do for this patient as an investigation? Yeah, this is very easy because doxorubicin causes cardiotoxicity. So this is easy. You are going to do an echo. Anti-Rho, anti-La positive, how to monitor the baby. How to monitor the baby in means of fetal growth assessment. Echo at what time? Okay, we do the echo for the babies, for the mother who have sickle cell with anti-Rho, anti-La between 16 and 18, and another one at 20 weeks. And then you are going to perform gross surveillance from 24 weeks. They like the follow-up. They like the follow-up. They love it. Any follow-up of diabetes with retinopathy, follow-up for sickle cell, follow-up for thalassemia, any follow-up for HIV and the PEP, postpartum, follow-up for lithium. You have a question for lithium, but very, very easy, not like the previous one. Yeah, yes, thank you so much. There was a top article about opioid misuse in pregnancy, and for how long the baby should be admitted in the hospital. At least 72 hours. This is the top article, guys, and you have the summary of this top articles in old but gold. At least for 72 hours. You have a case for what? For, yeah, and NYHA 3, class 3, in labor. Okay. What is the station? What is the station of this patient? If she is in mid cavity, then you are going to use the mid cavity forceps. If she is the head on the perineum, you can use the ventouse. But you need to shorten the second stage as much as you can. Yes, thank you. Thank you. Remind me of a question that I didn't know the answer. Even I didn't know the answer. The question about the postmenopausal woman with tube-ovarian abscess. Right? I need the details of this question. Because there is no details about the management of tube-ovarian abscess in postmenopausal women. We don't have details. If this woman is in acute condition, then you should remove it. But they told me that the antibiotics were given and now she is settled. Is that true? She's now settled. Okay, guys, it's different. If she's now settled and her symptoms are okay and everything back to normal, okay? Then we need to reevaluate the case. We need to reevaluate her. So that's why I was conflicted about the right answer. They told me she has taken antibiotics and her signs and symptoms were settled. Yeah, I know that COA in post-operative ladies are about like 40% to be malignant. Okay, but what is the next step? I need to know the options. Is there MDT? Is there another scan?
Dr. Nada, this question option was that you were discharged here on a 14-day antibiotic only, or you were discharged here on 14 days antibiotic, then you will bring here another appointment to remove the tube ovarian abscess to excise this abscess, or other options there was to discharge here on 14 days antibiotic and to give her appointment with MDT, gynae oncologist MDT.
Oh.
Or you will discharge here on antibiotic only, no appointment or any follow-up.
Okay, honestly, she needs a reassessment. She needs to be discharged on the antibiotics and to be reassessed. Either with ultrasound or
I searched for gynecologist only to give her appointment after 14 days, but there was no option. Only the option with MDT, multidisciplinary team, was gynae oncologist.
Yeah, options are always are very, very conflicting. And I'm sure that not all of you.
Because in this case, if there was an option to do for her, to bring her again and do bilateral salpingectomy,
no, I won't do this. I won't do this. I won't do this from my own.
But this option not in the question. So the one who is near to this is to give her appointment with MDT to review her. If no cancer, they will remove only the tube ovarian abscess. Or if there is suspicious of cancer, they will do the bilateral salpingectomy.
Okay, the best answer would be to reassess the patient through further investigations, or even to refer her for MDT. But to take the leap to remove the tubes, no, because she's not acute. If she's having acute symptoms now or she's in shock, yes, I would go for removal of the tube. But if she responded to antibiotics, she needs a reassessment all over again.
No, they write this patient very good condition. She respond rapidly for antibiotics.
So she needs a reassessment.
And there was no nothing to worry, no Pyrexa, no anything. So they decide to discharge her on antibiotic, but they give this option: 14-day only antibiotic, 14-day and remove the tube ovarian abscess, 14-day and bring her for MDT discussion, or discharge her without for 14-day only antibiotic.
Okay, I'm going.
There was no other option
to write down. To write down what I had collected from the TOG article topics that I had. If you can remember anything else, please tell me.
This question is twisted question in this exam.
Yeah, we have diabetic ketoacidosis, pancreatitis. I think there was 2 questions about pancreatitis. Transperineal ultrasound, this is a new one. This is a new one. They asked about the gold standard to diagnose
Yes,
elevator
this is
care.
a new one. This is new question. This by exclusion, because they give another option that not match this يعني
Why by
for
exclusion? It's mentioned in the top article clearly. Clearly, that's
yes, there is
tomography.
yes,
Tomography
yes,
ultrasound is the gold standard technique to diagnose
yes,
elevator in eye tear.
yes, the Dr. Nada, of course, but we didn't read all the talks.
I know.
So
I
this
know.
talk, this talks, I realized it after came from exam. There was a talk about this assessment. Of course, it is a surprise for us in the exam, this question.
Okay, we have headache. Okay, we have
But
hypnatremia.
I think the question of transperineal, it was not the transperineal in the option, it was translabial. Translabial and transvaginal.
Yeah, translabial, not transperineal.
They are the same.
أيوة.
They are the same. They are the same. They are the same.
Oh, I see it on the same.
It's
Dr. Nada,
called
translabial
translabial,
is
but,
out anterior.
Yeah, it's
both
but
the same.
transperineal
Both
is
the
down
same.
posterior.
والله ما تزعلي اهي translabial ultrasound. But the answer is
يعني
not
يعني
translabial ultrasound. The answer is tomography.
Translabial
الأنسر ليه؟ What is the
ultrasound.
answer?
The gold standard investigation for diagnosing levator in eye tear is tomography, not MRI. No.
There was also a question about trauma, which is the best imaging modality for pregnant with severe trauma.
This is easy, whole body CT. Trauma in pregnancy?
Okay, because there was another option, I think I read somewhere, I don't remember, which is trauma ultrasound, يعني abbreviation كده of trauma ultrasound like this, but I think this American college guideline, يعني I didn't remember.
No,
it
it's not the
conflicted me
RCOG.
somehow.
Yeah, I know what you're talking about. This is fast.
Yes, fast. Yes, that's it. So
fast is
somehow, but I also
and can you hear me? Fast is the way we have learned in the ATLS, the Advanced Trauma Life Support course.
صح, you're right. So yes.
But for the RCOG, when you have a pregnancy with multiple traumas, you are going to order full CT. If I'm wrong, you can correct me, by the way. Because sometimes I conflict the guidelines together.
Yes, Dr. Nada, this is the full body CT. It is in the trauma talk already.
Yeah,
they write even on this one, that one infographic also.
Yeah, I know, but I'm telling you, I have done her mistake before. I think I have done all your mistakes before. MashaAllah. I'm always repeating my mistakes in a new way. Like sometimes I'm conflicting guidelines. Sometimes I'm being stupid, like choosing one answer and then choosing the wrong one for the same question. I re-question my answer. Sometimes I don't. I read quickly without taking care of the details. I have done every single mistake that you can imagine on the planet. Wallahi, I did it all. You are talking to the expert, expert of mistakes. So don't worry about it. I have been facing time management problems, and I will tell you how to complete this, inshallah. But can you see the list here? If you can say more, please tell me. This list, what I can see here, most of them are classic tongues. Most of them are post-operative complication tongues or surgical tongues. Not all of them are new.
It was all in exam. It was all in exam about three things. About emergency situation in obstetric,
yes,
emergency in labor room, emergency situation in gynecology also.
So you agree it's a fair exam? You agree now that it is a fair exam?
There was Mullah?
Yes.
There was a question
yes.
about CRB for the neonate, the frequency of
Yes,
the
neonatal
contractions for
Neonatal resuscitation,
ventilation.
yes. Yes, neonatal
So
resuscitation, and
the
of course there
number
was adult
was
resuscitation in
30
pregnancy
to
also.
2 or 15 to 2.
You
The
need
adult
the time
resuscitation was
of
considering
compression.
yes, for neonate, it was time of compression to time of ventilation. This was the question.
Okay,
But for the
for neonates,
yes, I don't
we do
remember
3 to
also.
1 for 90 minutes. For neonates, we do 3 to 1 for 90 minutes. The question of headache. Oh, this one is good. She's having headache bilateral, pulsating, associated with photophobia.
And phonophobia also.
And
they
phonophobia,
said.
okay. What else? I have a very, very important details in my recalls here. The headache is increasing with coming up the stairs. Right? So I'm having two differential diagnoses. Is it migraine or is it exertional headache? And at waking up, this is new. Good detail. Are you sure from she was having the headache on waking up? Because if she's having the headache on waking up and with physical activity, and there is photophobia, phonophobia, nausea, and pulsating, this is migraine, even if it's bilateral. But if it's only with physical activity, with the same feature, this could be exertional headache. Every single detail can count.
But I think they give this question as aura. There was aura.
There was nausea, phonophobia, photophobia, and
there was photophobia and phonophobia. Phonophobia and photophobia.
Okay, was it walking or waking up? Because I have here walking up the stairs.
No stair. I didn't see there was an walking stair.
Okay, anyway, we know now that we are between migraine mainly, but when he said that it was generalized, not unilateral, it was generalized headache, pulsating.
Not generalized, bilateral headache.
Bilateral, okay. So it can be migraine, of course. Migraine can be bilateral. But if we are talking about headache, when she wake up from the bed and when she do the stairs and there is photophobia, this is typical migraine. The only untypical feature is having it bilateral. This is the only untypical feature.
It was bilateral, but all going with migraine.
Yes. Okay, we got collapse. I know. Oh, you got a very interesting case about collapse. This girl or the pregnant woman who was admitted in the hospital, and they tried to resuscitate her for 35 minutes, and then you come and they asked you what to do.
To stop resuscitation, which is what my answer. To stop resuscitation because already
yes,
35 minutes have been passed.
There has been 35 minutes with asystole. What else would you do? Nothing to be done to stop resuscitation, of course. Okay,
there was another
questions about HRT. I just want you to tell me if there was something
for
difficult.
collapse about
Look at this list and tell me if there is something difficult here other than what we
the
have discussed.
yes, the other question of collapse of which medicine we will give after 3 shocks. Which drug should we give? IV amiodarone or IV adrenaline
IV
or IV
adrenaline.
noradrenaline?
Of course, IV adrenaline.
But I
After
think
3
in the
shocks,
hierarchy, they mentioned that amiodarone should be given after 3 shocks. That's why.
you are going to give IV
It was
adrenaline. And if it's
this
not there, you are going to give IV amiodarone.
this question was according to the resuscitation.
We have a
This one algorithm.
resuscitation algorithm, guys.
Resuscitation algorithm. It is this one according to the how she revised. If it was ventricular fibrillation, and this question was ventricular fibrillation.
Yes.
After the third shock, we have to give amiodarone, not adrenaline.
It was
Adrenaline, we
VF?
are giving if it was, yes, it was VF. It is not pulseless electric activity or asystole. It was ventricular fibrillation.
Okay, so you gave her 3 shocks and she's not coming, right?
So it is this one, the answer is amiodarone, is not adrenaline.
Anyone can tell me the question in detail, because I will
Yes,
be
I
really
think
sad
it
if you
was
did this
like
wrong.
what the doctor told like this. And I was confused also between adrenaline because they didn't mention in the question that they give her adrenaline. But it was clear enough, like the algorithm, that after 3 shocks, we should give amiodarone. This is what's mentioned in the
Which
algorithm.
guideline
That's
are
why.
talking about? Which algorithm?
This was
There is
The collapse one?
I will try to bring.
there is
Yes,
algorithm
collapse one. Yes.
for this one for
The collapse one or
postpartum
the pregnant one?
It is not the collapse of a pregnant one. It is the this one in emergency
Resuscitation Council,
algorithm.
UK.
Yes, yes.
Okay, let me. I will open it with you. Maybe we can remember together. Because this question makes me so sad when you answer it incorrectly.
And also in the question of peripartum cesarean, they told if the baby given within 13 minutes of resuscitation, it will be also good. So it is also this one answer for peripartum cesarean section, not to stop resuscitation.
There has been 35 minutes of resuscitation and the patient
Yes,
was
yes,
uncontrolled.
it is not our job as gynecologists to stop the CRB. Our job, they called you after 30 minutes, they called the gynecologist. Already the team of resuscitation was there.
Doctor, you are going to do a peripartum incision or the postmortem incision.
Yes.
The
This is
postmortem
our rule.
incision is done within 5 minutes of resuscitation, not 35 minutes. What the postmortem cesarean section would benefit her now?
According
why
to
you do postmortem cesarean section? Why you do it?
According to this, the peripartum cesarean talk, it is written that even 30 minutes past, still you can give them.
Really? Really?
Yes.
You can do a postmortem cesarean section after 30 minutes?
Yes, we can go to the talk and see. It is written.
No, dear. No, the postmortem cesarean section.
Yes, but the question, the question, the patient come back and collapse again. There was something in the question that the patient come back and collapse again.
Okay, let me clear it. I have a question talking about an admitted patient, okay, for whatever, and now she collapsed, okay, and the resuscitation team works without you. They forget to call the obstetric team, and after 35 minutes they realize that the obstetric team has not been called because there was something like malfunction in the system or something like this. And when you came, There is 35 minutes have passed and this woman is at a stone. This woman is brain dead. What you are going to do to her? How the post-mortem cesarean section will hurt her? She's at the stool for 35 minutes. Even with this, we do, Dr. Madhingi, we do the post-mortem cesarean section to save the mother, not the fetus. We do it to save the mother. After 35 minutes, please, anyone can tell me how this would help the mother? 35 minutes of asystole.
I am searching for evidence now.
It is mentioned very clearly in the talk article that perimortem cesarean section should be done within 5 minutes of resuscitation, failed resuscitation. Only 5 minutes.
Dr. Nada, when he say perimortem cesarean section, he said we are checking the fetal viability first, and then we will do perimortem CS.
If it's
Or
more than 20 weeks, of course. Yes.
Yes, he said in the option, he said perimortem cesarean section after assessing the fetal viability. Okay, that the baby is viable or no, and he given two options.
I don't care.
Viable,
I don't care if the baby is alive or not. I'm not doing it for the baby. I'm doing it to save the mother.
Even the patient, even the mother is died. If the mother, if we say the mother is died and the baby is 24 weeks, we will not saving the baby. We will let the baby die also.
This baby has no rights. The baby intrauterine has no rights. He's not a citizen. Your aim is not to save him.
This is the conflict. The patient, okay, it's if we are assuming that the patient is died already, okay, because she's 35 minutes asystole and she's not coming back. But the baby is 24 weeks. So we are assuming that baby is 24 weeks, so we can save the baby. So I am self choose that I will check the baby fetal heart.
I will share it with you. I will share it with you. So this is very important, guys. This is really important. Not for the exam, not for the exam, for you.
Yes.
See here, okay? We applied the defibrillation pads.
There is talk about the perimortem cesarean.
We are coming to the perimortem cesarean section, don't worry. Here, we are going to apply the defibrillation pads, okay? If it's VF or pulseless VT, you are going to do another defibrillation, right? And then you are going to give the first adrenaline or amiodarone after the third shock, right? More details are written here, and more and more details are written in the guideline itself, this guideline, Resuscitation Council UK. Adrenaline is given in non-shockable reasons, okay, or after third shock. If it's not there,
question was
or it's bradycardia, you can give amiodarone. Okay, here. If it's CEA or asystole, you are going to resume the TPR and give first adrenaline immediately. Why? Because this is non-shockable. There is asystole. Okay, this is non-shockable. You are going to give adrenaline. Okay, agree?
But the patient have ventricular fibrillation.
Okay, this one.
In the scenario.
This one.
Ventricular fibrillation.
This one. Defibrillate. She's not coming back. Defibrillate. She's not coming back. Defibrillate. She's not coming back. Give adrenaline. Wait for 2 minutes and then defibrillate again. Continue CPR all through. Don't stop CPR at any point. I remember saying this. I remember saying this very clearly. for the perimortem cesarean section. Look here. Perform by 5 minutes if no return of spontaneous circulation. The problem is you were not there. There were malfunction in the system and the obstetric team didn't come. Only the resuscitation team worked on this patient. So there has been 35 minutes passing. And by the way, I think this patient was postpartum. She was not pregnant. Or she was pregnant. I don't know. Why she was admitted? Did they say why she was admitted?
अंदर
Can you
आवाज
hear
जा
me?
रही थी और बच्चे सोए हैं। नहीं मैं ध्यान ज्यादा सही हूँ।
Okay, anyway, what's done is done. Let's go back here. We are here today not to make you regret anything, guys. We are here to know where our point of weakness. You are going to realize it. You are going to realize it. If it's weakness in my type of study, the way I'm studying, or paying attention to the details of the question, or is it only time management? Yes, dear, it will be adrenaline. Wallah, I said it many times. I'll be adrenaline. Amiodarone is given if adrenaline is not there. But there is something called adrenaline shock. It's in the trolley of resuscitation. Anyway, can you remember anything other than those? There was a question about BRCA 1 and 2. I think SBA, most common cancer, most common ovarian cancer with BRCA 1 and 2. Adrenaline first, then amiodarone. If you read the whole guideline, I can send it to you. Yes, thank you, Dr. Nadis. So yes, there was a question about what type of ovarian cancer that is most common with BRCA 1 and 2. This is high-grade serous cancer. And by the way, this is very old TOG article. Opioid misuse is old TOG article. Fibroids is kind of old. Donor oocyte IVF, I think the complication that that is most common to happen to the mother, or was it other thing? Yes, don't regret it, guys. What's done is done. We are not here to regret anything. We are here to learn from our mistakes. If you don't do this, you need to regret it, honestly. If you have gone to an exam and you haven't learned from your mistake on this exam, then you need to regret it. But if we are learning now from our mistakes, my aim today is to make you have or highlight your weakness. You need to highlight where we went wrong. Where we went wrong. Is it lack of knowledge, or misinterpretation, or time management problem, or is it a stress problem? For example, I'm someone who has a very big stress problem in the exams, very big one. I can literally skip some words. I don't see some words in the question from stress. I can skip some options. So this is something you need to work on. Maybe you need to calm down, take medications. You have to do something. If it's lack of knowledge, now I know the resources of the exam. We can get back. I know that the exam is not only GTGs, is not only talk articles. No, the exam comes from Embrace reports. The exam comes from FSRH. You had many questions about contraception. Am I right or no? Wrong. You had many questions from behavior, the HIV guideline. You have questions from the BASH guideline. Did you have a question from the European Society of Cardiology, like January batch or not? Do you have anything talking about cardiac diseases, complication of cardiac diseases, or risk assessment of cardiac diseases, something like this? There
I
was a
think
question
only
in
the
January.
question of cardiomyopathy after preeclampsia.
No,
There was
this
a
is not
case
the
of
European Society. European Society for Cardiology, they are mainly concerned with congenital disorders and how to manage it during pregnancy, like valvular diseases or syndromes. No, this is not also the guideline. This is a nice guideline. The NYHA3 in labor, we need to do anything to shorten her second stage. So according to the vertex, if it's in the mid cavity, I'm going to use a mid cavity forceps. If it's low cavity, I can use low cavity forceps or vacuum. She's hemophilia, the same one. The cardiac case is a carrier for hemophilia. If so, you are not going to use any instrumental delivery. Okay, I'm talking in general now. Okay, hemophilia in labor, you are not going to use any instrumental delivery. You are going to exclude any option that talks about instrumental delivery.
Excuse me, there's a question about NIHA 3. The patient was not delayed, yani she was progressing well, and
Yeah,
I
I
think
know.
she was fully
Even
dilated.
so,
Yeah,
even
so
so,
we should
it's not
use
about delay. It's
something.
not about delay now.
So he was talking about the safe, what to use in anesthesia in this. Yani she should do forceps with general anesthesia or forceps with bedondal block.
I
This
will
was
choose
two
Udendal block.
options.
I won't go
Yes,
for
okay.
general anesthesia.
Regarding the cardiology question, there was a question about sickle cell disease, when to assess her heart before pregnancy or with pregnancy. Yani within, I don't remember very well, but I
The
think within
patient
2 years.
heart or the fetal heart?
No, the patient. She was sickle cell disease, and he want to assess her
yeah,
cardiac
okay.
status
Okay,
before
I got the
pregnancy.
question. I got the question now. If she does not have a recent echo
Yes.
for 1 year,
Within?
you should repeat the echo. The echo should be for at most 1 year. If it's more than 1 year, you should repeat the echo again. Is this the question, right or no? Or what?
Yes, you are right. But we are
Yeah, I'm playing now. والله أنا حاسة إن أنا ساحرة.
ما شاء
I
الله.
hate recalls. I
هو
hate recalls.
الدكتوره ندى بعد كده يعني اذا كتب لنا عمر ان بقى نخلي اللقاء ده بعد الامتحان بيوم او يومين تبقى لسه الذاكره فريش. احنا نسينا فعلا، عدى اسبوع اهو. يعني within
It does
1 to
not
2
matter.
days it will be
والله,
better.
my aim is not to correct the questions. This is not my aim. This is not my aim at all. I'm now evaluating my resources. Did I do my best with top articles, or I should have read more? Did I cover the guidelines correctly, or I just read it in like shortcuts? I just read the shortcuts. I'm not aware of the tricky points. I'm not aware of the specific follow-up for each disease. I don't know the postmark. I don't know. But I expect to find it so low. I expect this one would be like 62, 63, 65 at most. Because when everybody say that this exam is difficult, the recent one in January, it was more than 60. I think it was more than 60.
It was 65, I'm sure,
Yeah,
because
yeah.
I passed that
No,
exam, I failed
this
it.
one would be
It was
60,
65.
62, something like this. Because, you know, guys, they know the exact amount of candidates who is going to pass. They decided it. And then they put all the marks on the curve and they take the confidence interval. So you got it? So expect, yani, be optimistic when you find this exam is difficult, be optimistic. If the exam is easy, this is when you need to worry. So I need you to evaluate your sources, get back and see if you missed any resource before. If you haven't given TOG articles and GTG enough attention, you should do it now. And what are the hot topics? Is there any change in the hot topics? I think no. I think no. If there is 1, 2, 3 questions totally new and we don't know the resources, forget about them. Those are not going to be the cause of your fail. If you fail, it will be because you have missed basic questions, like basic gynecology question, early management, early pregnancy management, for example, or emergency question, or something with obstetric cases, intrapartum care. Those kinds of questions that, yeah, they can make you lose marks, high marks. But if you lost a question about TOG article, so whatever. If it's only one TOG article that you have done it unwell, it does not matter. It does not matter at all. Okay, I have now silence in the room. All are depressed. Wallah, I tried my best not to correct answers for this. I don't want you to be depressed. It's just an experience. It's just an experience. Don't be depressed. You are not like someone in elementary school or high school. You are doctors now. You are doctors. This is a postgraduate exam. This is a specialty exam. This is not an easy thing. If you pass it from the first time, you are lucky. But it's very normal to pass it from the second time or the third time. This is very normal. I didn't pass it from my first time. Okay, and by the way,
it was the third time, Dr. Nada, the matter that we really stopped our life for this exam.
I'm not a good mentor, okay? I don't expect myself to be a good mentor. All good
You are
mentors
excellent mentor.
have failed this exam once or twice. The more you fail, the stronger you are. Wallahi, the stronger you are. You are going to be strong even in your practice. If only you are studying well. If you are taking it lightly and just revise 2 months before exam and you say, why I'm failing now? You are being a joke. You're joking yourself. This exam is a hard one of the hardest exam on planet. This is not an easy exam. You saw by yourself. If someone was lucky before to pass it from the first time, trust me, he has been struggling with part 3, 2, 3, 4, 5 times. So don't evaluate yourself from such an exam. This is not you. And don't evaluate your professionality and your competence as a doctor from an exam. No. Exam is not only about knowledge, it's more about stress management. time management, how you cope with everything going around you. Many of us have families and have emergency cases. And I had an incident before my exam, just before the day of my exam. How this will affect you. I know many of you had sick family members just before the exam, right? How would you deal with this? I tell them, just go and try it. Consider it a mock exam. Don't consider it the final shot for you. Just consider it as a mock exam. But really, if you are not going to learn from your mistakes, this is failure for me. This is total failure for me. If you are going to repeat the mistakes all over and all over, this is failure. No, I need to know my weak points. I know now that I have a weak point regarding studying. I'm not studying correctly. I'm studying very hard, not smart. I'm reading, but I'm not gaining any good information, because when they ask me about the follow-up of a maternal disease, I don't know, or I don't remember. This means that you are not studying correctly. You have focused your study on risk factors or some numbers or maybe general points. But when it comes to antenatal care, I was weak in antenatal care. I need now to focus more on antenatal care. I feel, for example, that I was weak in all topics regarding TOG articles. Then I need to focus more on TOG articles. At least I will read it once without a summary, and then I will revise it from the summary. For example, another example, the obstetric care. I know the answer, but I'm not really sure. I'm not really sure that this is the correct answer. This means that you don't have a solid concept. If you are not sure about options in obstetric intrapartum care, you are not having solid concepts about intrapartum care. So I need to ask, what happened if this? What should I do if this? And the college is blind, guys. The college wants us to go through steps. They don't want you to think much. They don't want your opinion. Don't have an opinion. If something is having algorithm, move through the algorithm. If something has steps, move through the steps. Stepwise management. We don't need your opinion in anything. Wallahi, that's the case. If you are answering the question with your opinion, you are going to fail. You need to answer according to the college perception. What the college has put in the guideline, what the college has put in the top article, what has been written in the algorithm. Okay, if this is okay for you, if you get those points, then my job is done here. And we can spend all the time in the world to correct that question. It's okay. I don't have a problem with it. But I need you now to take a breath, forget about the result, forget about it at all. If you believe in Allah like I do, I believe that what's written is written. What's written is written, guys. If it's written that you are going to pass, you are going to pass. If it's not written, you are not going to pass. And in both cases, it's for the best for you. Wallah, it's for your best. If I didn't fail 1 and 2 times, I wouldn't be here teaching you. If I passed from the first time, I would not be studying again from another perception. And when I study in a very unsmart way, in a very stupid way. I study very deeply. I'm a very deep studier. And this is very, 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 very bad thing for anyone who entered the exams. You are going to find me know many things and many information, but when I go in the exam, it's very bad, very bad. because I overthink. I know too much. So my brain is like going here and there. No. It's not like this, because I know that it has something to be related with this thing. The overthinking in exam is a very bad thing. Very bad. But it's good in another way. It's good because when I teach pre-graduates now, they think that I'm an idol because I know too much. I told them, no, I don't know too much. I just read too much. I have read too very much. So that makes me fail once and twice. But now I'm a teacher. For you, it will also be like this. You are going to be a strong doctor. You are going to be a stronger doctor in your career because you learn every day. Every day you learn more. Every day you learn something new. You are going to be special within your team. If you are outside the UK, you are going to find yourself special. Tell me honestly, in your facility, does anyone know how to manage a sickle cell disease patient? Honestly. Tell me, do you think that your colleague can manage a patient with sickle cell disease, with renal failure, with autoimmune diseases? Do you think he can? No. I don't think so. Yes, even with diabetes, unfortunately, yes. Yes, wallahi, even with diabetes and hypertension, they do mistakes. So mashallah, now you are a real specialist. So don't let an exam define you. Okay, guys, I know you did your best. We all have flaws. We all have flaws in studying. Yes, Dr. Vani, of course.
Yeah, Dr. Nada, thank you very much for this session. I just want to know that how the passion to study should be maintained, because when we read for the first time very nicely, we are very passionate and very energetic and very enthusiastic to read all these things. Once we fail, like I failed by 1% previously. So once we fail, the enthusiasm goes down. So how to, definitely we have learned so many things new, and definitely we know better than others at par, as you said.
You
But
are a human
how
being,
to
Vani.
maintain
You
that?
are a human being.
How to? Sorry,
You are a
ma'am.
human being. You should feel low when you fail. It's normal to feel low, but it's not normal to let this low feeling get you and make you think that you are a failure. No, you are not a failure. It's just a trial. Why do you think the college is giving you the opportunity to give the exam more than 10 times? There is infinite times. For outsiders, for outside the UK, you can give this exam 100 times. Why do you think so? Because it's not easy. It is really not easy. And the people who take the exam with you will affect your total score. It's not fair, but this is how it is. If you are taking the exam with very high scores, probably you are going to fail. If you are taking this exam with people who are moderate, there is high chance that you can pass. It's not fair thing, but this is how the college remark the questions and take the total pass score. Guys,
Okay.
please don't feel low, okay? Inshallah, Allah is not going to waste your efforts. Never, never. Be sure of this. If you are not going to take it as passing this exam, you are going to take it otherwhere. You are going to be better in other fields. Make sure of this. Okay, I don't want to speak in Arabic much, but and subhanallah, إن الله لا يضيع أجر من أحسن عملا. So be sure that Allah will never ever make your good effort be in vain, ever. What you have done through studying and struggling with your family and everything else, waking up at night, I know this. If I know this, Allah knows it too. And He's going to reward you in His own way that is best for you. We don't know what is best for us. Honestly, I cannot add anything else. So if you have any recommendations about the course, of course, you can tell me in private or in the group, whatever you like. If you wanna say it out loud, what is in your heart, I'm here. You can tell me whatever you like, anytime. Voice messages, writing, anything. Express your fears, express your anger. I know you are angry from yourself for some stupid questions that you mistaken. This is all normal. Get it out. Don't let it in. Get it out and hear yourself. Hear yourself saying, why I did this, why I did this. I have to take care of this. I have not to repeat this mistake again. Okay, I'm here for you. You can send me anytime, anything. And if you need me just to listen without commenting, I would do it. Thank you so much, guys, for being here today. And really, we have taken so much time. I didn't think you were going to be alive after 3 hours. Thank you so much.